suicide rates, the adjusted suicide rates between veterans and non-veterans. And we see this trend continue today. Now, what we do know is that approximately 70% of the country's 20 million veterans do not access the VHA for their health care services. And this may be from choice, or it could be based on eligibility or distance or any number of reasons. But we do know that the majority of veterans do not access health care outside of the VHA healthcare system. Do access health care outside of the VHA healthcare system. So looking at the capacity for those providers that are in the community outside of the military and the VHA healthcare system, we get a sense from some reports and some studies that have been done, such as this, the RAND study from 2014, that took a look at mental health providers in the community and their self-reports on military cultural competency. And what we recognized was that approximately 70% of those mental health providers in the military and VA settings consider themselves to have high military cultural competency. Moving to the TRICARE network, those folks that are outside of the military settings but still have a degree of contact with those veterans and service members, such as National Guard, consider themselves to have approximately 24%, or 24% of those folks consider themselves to have military cultural competency. And then moving to the community providers that are neither in the military settings, VA, or the TRICARE network, it was found that only about 8% of those providers consider themselves to have high military cultural competency. So those statistics, the 70% of veterans who do not access health care through the VA, combined with that 8% of community providers who consider themselves to have high military cultural competency, have major implications for at least mental health service in the community at large. So some key considerations for addressing crisis care for SMVF are what are some of the key factors that contribute to suicide ideation and attempt. So understanding those is what we'll try to dive deeper into today. What evidence-based practices can be taken to support SMVF at high risk for suicide, and which tools are available to support these evidence-based practices. With Dr. Hogan's help, we'll address some of these key questions as well as some of those that you continue to bring forth using the question and answer box on your right column as we move forward through this process today. Before we move forward, introducing Dr. Hogan, I'd like to bring forth a poll question to the audience. So we'll provide about half a minute, about 30 seconds for you to consider this question and just select one of the three options available. So we'll take a couple of seconds. Please answer this question. Are you aware if acute care providers in your community screen for veteran status? Have about another 5 seconds. Okay, and based on these brief results, looks like it's tabulating a response. Give it another 10 seconds or so. And it appears that based on the information provided here, the majority of those who did respond are not sure if acute care providers in the community screen for veteran status. So throughout this webinar, we will talk a little bit about why that's important, as well as screening in general, why it's a key practice going forth. So at this point, I'd like to introduce our speaker, Dr. Michael Hogan. Again, serves on the executive committee for the National Action Alliance for Suicide Prevention, who will discuss some of these key practices in crisis care and suicide prevention. Dr. Hogan?
Thank you, Don. It is great to be with all of you today, and I want to begin by thanking you for your time here today, and more significantly for your commitment to this mission of saving veteran lives. It is a problem that finally, with this effort, we are starting to try to get a grip on in this country. The next slide, Don. This is what I want to try to cover in the next bit of time with you, and you'll see this emphasis here on doing what works. This has been a frustration for me that by and large in suicide prevention in general, we're not doing what is proven to be effective. Similarly, with respect to the question that Don started with, if we don't know if a person is in crisis, if they have served, we are likely missing a key component of who they are, of what's going to be helpful for them, and possibly we may be missing something about experiences that have contributed to their crisis. My urgency about this issue grew over time. As Don said, I spent 25 years trying to run state mental health systems. The last 5 or 6 of those were in the state of New York, which convinced me to give up. But over that whole period of time, working on many issues in mental health, I always got a sinking feeling that we weren't doing enough about suicide prevention. In both Ohio when I was there and then in New York, I had the opportunity to start organizations in the community with some state support that would focus on suicide prevention. And we had good people in both states involved in those organizations, working hard, working what at the time they felt they were supposed to do. And I began to get a feeling that we were not making a difference. And so I've been on a quest for about the last 10 years that took me, in a sense, from the field of mental health into the field of suicide prevention, or the intersection between those two fields, to try to figure out what actually is effective and what could we do. The good news there is that there's a tremendous amount of new knowledge, and it's in the last 10 years about what actually is effective. That's what I want to try to cover for you. And surprisingly, or maybe it's not surprising, the new knowledge about what's effective often suggests that it is simple and small things that are particularly effective with respect to preventing suicide. I'll just leave that up there as a kind of a mystery. Now, I want to acknowledge that some of you may have heard a briefer version of this presentation at a Policy Academy or a SMVF conference, but I'm going to go a little slower today and hopefully provide a little bit more detail on these points. Let's use what's evidence-based. The good news is that we now know what's effective, although it's not business as usual. And this information is going to lead us in the direction of a proposition that to save lives, we've got to identify and do something with the people that are at greatest risk. If we try to spread our mission, our shared mission, across entire communities, we're likely not to go deep enough to make a difference. So we've got to focus. And I'll spend some time throughout the presentation and then at the end suggesting some steps that you might take in your communities and some resources that are becoming available. One of the perspectives for me about this is that on this theme of doing what works, we see here a slide of data over the last 20 years or so. It actually goes from 2003 to 2013, but the trend lines have continued as they are here, showing the age-adjusted rates of mortality in the United States for cancer, for stroke, for heart disease. You see stroke is at the bottom. The line of all-cause mortality, all the reasons why people die, is buried in there. And at the top, while these other major killers are decreasing in impact, the rate of suicide has gone up. So obviously, we are not doing what they have done in heart disease. So it set me on a quest to try to figure out, well, what have they done in cardiovascular disease care that's effective, and can we learn from that? And so one of the messages pretty clearly is that if you want to do big work, you can't do just a little. And I'll illustrate that through one data point, which is that, well, actually, let me provide two data points. One of it is to look at national spending on research into our cardiovascular disease and its prevention and cure, compared to research into suicide and its prevention and cure. And the last year that I had access to comparable data, we spent $1.3 billion on cardiovascular disease, and we spent $40 million on suicide. Now, heart disease is a bigger problem, so we ought to be spending more, but $40 million is just not adequate. So we cannot expect results without adequate investment. So here's another example that's a little personal. The last time any of us went to the doc, they put on a blood pressure cuff and took our blood pressure, which is a good, simple indicator of risk for stroke, blood pressure, but also potentially for cardiovascular disease. If we were to sort of slow this down and do a poll to say the last time you saw your doctor, were you asked about suicide, the answer would be for 2 to 3% of us, we might have been. That's starting to change, but it's not changing closely fast enough. So you can't do a little and expect the results that we are tending to achieve. The second question here is to look at, in the area of heart disease, what has led to these improvements in outcomes? And there's sort of two answers for this. The first answer goes back to like the 1960s or the 1970s, before we developed a national, a pretty consistent national approach, or broad national approach under 911 and for emergency response systems in general. When we put that in place, when we put 911 and emergency response in place, that had a 50% impact on reducing deaths from heart attacks specifically, because people got good care sort of right away. Since that time, once we had the basics in place, the biggest reductions in cardiovascular disease deaths have not been from interventional cardiology, things like, certainly like transplants or valve replacements or high-tech surgery on the one hand, and with one exception, they haven't been at the pure prevention end of the spectrum either. If you don't see, maybe dietary habits are starting to change, but we still have a problem with weight in this country, and we still have a problem with diet. The one area where we have made a difference is in smoking, where we've had over 40 Surgeon General's reports. We've got higher taxes on smoking. We have constant messaging about smoking, including labeling on every package of cigarettes that's sold. And that has reduced the rate of smoking, which is a big driver of cardiovascular disease. So with the exception of smoking, most of the reductions in deaths from cardiovascular disease have come from identifying people who are at risk. Think about that blood screening, that blood pressure cuff, or think about the blood draw where your cholesterol gets checked. And it turns out that those two simple little tests for elevated cholesterol and elevated blood pressure have led to interventions, often drugs, sometimes just change in habits that have dramatically reduced cardiovascular disease deaths. So the question is, have we got approaches like that which could be deployed to save lives? Is there a way to detect who is at risk? And then are there simple and practical things that we can do to save their lives? And it turns out that there are things that we can do. As with heart disease care, we can't do just a little and expect a lot. So all of you are, pedaling against a pretty steep grade to get suicide prevention from, none to slim to good, to get recognition of veteran status put in place as a key component of this care. And it's going to take a little pedaling up that hill to get far enough up so it's beginning to make a difference. So we're going to have to do more on the one hand. But on the other hand, I think the data is pretty convincing that if we go out into our communities and do broad community-wide activities, we're not going to do a very good job of saving lives. For example, if I were to say are veterans at high risk of suicide, we might say, well, yes, they are. We've seen that data. They're at elevated risk compared to the general population. But if then I were to ask more specifically, well, what's for the average veteran, and there really is no average veteran, just like there's really no average person of any kind. For the average veteran, what's their risk of dying by suicide this year? And if you do the math, it would be, well, they have about a 1 in 2,500 chance of dying by suicide. Well, 1 in 2,500 is spread pretty thin. That means if we're going to do something in the broader community, we've got to reach 2,500 veterans to save one life, according to that approach. So if we had a full tilt boogie method to address this, perhaps we could achieve something. But these efforts, you didn't get giant amounts of funding to put together your teams. You got commitment and a little bit of training and support. And it's all it's volunteer and shared labor and commitment that is getting this done. So we don't have, it's not that we shouldn't be working on broad community-wide activities. I would just say, to be blunt, maybe to be provocative, it's not realistic for us to expect our broad community-wide activities to save lives unless we do them at an extraordinary level of effort. So that then takes us to the last bullet here. What is the evidence for identifying those who are at risk for suicide, just like the blood pressure cuff or the cholesterol test? Do we have similar approaches that would work for suicide? And then if we identified people that are at risk, what are the practical things that can be done? So let's go to the next slide. But before I go there, this is a little bit of a detour that I want to take to provide a different way to think about the problem of suicide. We've tended to think about suicide the way like the news media reports it. We have a rash of teen suicides. Teen suicide is going up. We have a problem with veteran suicide. Veteran suicide is going up. We have a problem with older men. That rate is going up. Or LGBT teens. That rate is going up. The thing about it is that none of those things are causes of suicide, first of all. And second of all, the vast majority of people who might fit into every one of those categories do not take their lives and are at very low risk. So the old ways that we thought about these risk factors, which I sometimes liken to driving with the rearview mirror, because we came up with these correlations by looking at people that had died and then by noting characteristics that they had. Oh, it was an older man, a man who died. Older men must be at greater risk. Or there was a veteran that died. Veterans must be at greater risk. But the rearview mirror doesn't help us very well when we're driving. We need to look ahead to think about what are the real risks for individuals that we can maybe do something about. And the best thinking about this comes from this book by Thomas Joyner. It's not called The Interpersonal Theory of Suicide. It's actually called, his book is why do people die by suicide? And Dr. Joyner has done a deep dive into this problem, and he suggests the approach that are outlined with these bullets. That first of all, most people don't think about suicide very much. When people experience pain, chronic pain, the loss of hope, when they lose something in their life, it might be spouse, it might be their mission, it might be their job, their career. It may put them at risk for escalating ideation or thinking about suicide. But even ideation, per se, is not a very great risk because many people have suicidal thoughts, but most of them don't make a suicide attempt. So in the United States, each year, according to SAMHSA, about 9.8 million adults will have thoughts of suicide. Well, that's a big number. How many actually make a suicide attempt or seriously harm themselves? And the answer to that is it's about 1 million people. So 90% of those with ideation do not make an attempt. So Joyner and these other researchers says it takes more than ideation for suicidality to become a serious risk. And there are two ingredients that he and others begin to think are critical. One of those is isolation from human relationships. Joyner uses the term thwarted belongingness, that people don't feel like they're connected to other people and they feel like they're isolated. And isolation, in this sense, is the poison that takes ideation from something that is merely bothersome to something that's really dangerous. And the second thing, besides isolation, that Joyner identifies as critical is developing what he calls the capability to kill yourself. Capability has both a mental component to be able to get over those things that would keep us from harming ourselves, which might be faith, or it might be family, or it might be fear, or the other reasons we have for living, or the reasons we have for not dying. So we've, in a sense, to develop this capability, we sort of got to get over that, which we don't want to do, but that's how Joyner describes this happening. And then once we get over that mental capability, there's the physical question of how to kill ourselves. So when somebody has been isolated and develops the capability, that's when this becomes dangerous. Oh, go up one, sorry. And so what turns out to be very useful in this regard is that clearly suicidality is a risk factor, but we've got to hone in on suicidality plus capability plus means. And the study referenced on the previous page that was interesting in looking at this was a study by Alex Milner and others at Harvard, where they did very detailed interviews of people who were in the hospital after a serious suicide attempt. And they tried to figure out what was the pathway from their first thoughts about this to a place where they had developed the capability to the actual attempt. And they learned three things. This is my takeaway from this research study. The first thing was that the average person in this study, it was 2 years between the time they first had the thoughts of suicide until the time they made the serious attempt. So 2 years is a lot of time for us to do something, but only if we know that they're contemplating it. The second thing they learned is once people had developed the capability, once they got to in a sense a critical mass, they kind of decided. Things move very fast. For the average individual, it was 2 weeks before maybe a tentative decision to take their life and the actual attempt. For some people, it was much shorter than that. So waiting around until people are very close is a very bad strategy. But the question that becomes raised for us then is if we can identify people who have ideation and developing the capability, then maybe we can do something about it. So now let's look at the research on that point.
So at this point, we'll pause. I know that as Dr. Hogan has gone through this initial information that some of you may have had questions arise, curious about maybe some aspect of what was just covered. Please feel free to type your questions into the Q&A box on your right-hand side, and those can be addressed. And we'll allow a couple of minutes for folks to type their questions in while we continue to, we'll step forward in a few minutes, but we'll give you a few minutes just to type your questions. So one of the attendees asked the question, is there a difference between ideation and thoughts? Dr. Hogan?
Well, ideation basically means thoughts. So, you know, as in the shared root word of ideas. So ideation is generally taken to mean thinking of suicide or possibly feelings that one might be better off dead. So thoughts or feelings that are specific to suicide.
Another question is, are there any up-to-date statistics? Most of the classes I've seen project stats from 2003 to 2013. Why is that?
Well, in this case, it's probably laziness on my part because that's where I got the slide from. But I've looked at just these general statistics from 2013 out till today. And they basically are continuing at the same rate. So the rate of heart disease heart disease deaths is going down. The rate of suicides is still increasing at about the same pace. Another
attendee asked if there is any research on veterans only related to the 2-year gap that you addressed a little earlier. I'm glad you asked that question. This was a question of adults, including young adults. They did not, as is typical, inquire about veteran status. It was a relatively small study because the interviews were so extensive. So we cannot say for certain that the same dynamics would apply, but I would suggest that probably it's not radically different for veterans and non-vets. And Dr. Hogan, what is your opinion about the isolation factor as it applies to active service members, considering they're around their teammates? Well, my just gut reaction to that is that I've heard so many vets and leaders in the veteran community talk about one of the challenges, especially for vets that have served, let's say, in this century, where combat is more intense, where unit cohesion is extremely important, and where people come back from having served and deploy out, and first of all, they don't have anything that replaces that intensity in their lives, and second, the incredible cohesion of working with comrades and buddies and being in deep with them is gone away. So the problem of isolation, I think, is particularly acute. And then for older veterans who might be Vietnam era veterans, the challenges may seem to come less from that experience of having served way back then, but it's the experiences of military service that are layered onto sort of getting old, losing roles, and other challenges like that. So isolation is certainly a key factor for veterans as well. Thank you. Dr. Hogan, Jason asks, or states that he works exclusively with homeless and at-risk veterans. other than advocacy and providing resources, what do you see as the best tool to address suicidality in the homeless population?
I hope that the material we'll cover next will address that.
Great. Just to let everyone know that's on the webinar now, a link will be sent so that you can access the slides and download them directly to your terminal. We have time for a couple more questions. From Gail, veteran suicide within VA campus is very troubling. What can be done to better prevent that from happening?
Oh, boy. Well, thankfully, that happens very infrequently. But when it does, it's just so stunning and shocking. I don't have precise data myself on suicide on campus, but I do know that closely related to that is suicide while in a hospital, which has been a big concern for a long period of time. And the Joint Commission has just done a study of that problem, and they looked at VA health system data as well as data from outside the veteran system, and found out that basically it's a tiny fraction of all suicides, less than 1%, that happen while people are in the hospital. 3 to 4 times as many deaths happen within the first couple of weeks after somebody leaves the hospital as happens while people are in the hospital. So that's, I guess, a part of a response to that question. And the second part of this that has to do with how shocking and troubling and even devastating it could be for us when we lose somebody that we're working with, or when they're in a location like on campus that we think ought to be safe. And the big implication for me about that is that the community of people who are working in a healthcare system, or a team of people like your teams that are working on a regional or statewide basis, needs to take care of itself. Because when we commit to this mission, it doesn't mean that we're going to get instantaneous results. And as we increase our commitment, we're also going to increase our vulnerability, if you will, if we have a loss. And it's going to hurt us more, perhaps, than if we hadn't made this commitment. And so for hospitals and health systems and for teams to be prepared to support each other, to get help as needed, just the things that we would suggest for other people are pretty critical.
All right. We have time for a couple more, I suppose. Mark asks about moral injury, that it's difficult to address in veterans. He said he's had several that have attempted suicide as a result of an event over a wartime zone. Can you speak more about moral injury?
I think that's beyond my pay grade. I think we'd have to have somebody that's more expert specifically in the veteran space. I consider myself more knowledgeable about suicide generally. I'm sure that there is someone connected to the VA who could respond better to that than I could.
And we'll take this last question from Elizabeth in regards to isolation. She says she's been connecting with veterans, connecting veterans to organizations like Team Rubicon, Team Red, White, and Blue, Mission Continues, and other VSOs. Do you find these community organizations to be beneficial to combat isolation issues in the veteran community?
Well, that's a lead-in to something that I'm going to cover a little bit later. And I think what I'll say is I think they are potentially a huge resource. The question is, and this is, I guess, anticipating a little bit what I'm going to say later, is there's no one better to reach out to a veteran than somebody else that served or an organization that is connected to that mission. So that's the huge possible benefit. The issue is, do the contacts happen? Because that's how the rubber hits the road. So I would say, if the supportive contacts happen, that may be, in my view, the best way to get it done. But we have to know that the supportive contacts are actually taking place, and we'll talk more about this in just a minute.
All right. So what we'll do at this point, we'll transition to a second poll for the audience. This question is, are you aware if acute care providers in your community screen for suicide risk? Please select one of the three options. We'll give it about 30 seconds for you to answer. Currently tallying results. We should see the results in about another 5 seconds or so. All right, so based on the responses from about a little over half the folks in the audience, it looks like the majority believe that yes, for the majority of those who did respond, did answer yes. Most acute care providers in the community screen for suicide risk. And there are the second most prominent was those who are not sure whether or not screening is taking place. So at this point, I'll transition back to Dr. Hogan to continue with some additional information.
So this goes to the evidence for suicide screening, and this is just one study that I will cite, and my take-home point here is that screening works. We have to be prepared, obviously, to respond if somebody screens positive, but screening is a pretty good way to identify risk. So this was a study by Dr. Greg Simon. You'll see it's relatively recent, just from 2015. And they pooled data from multiple health systems and insurance plans, which had access to both insurance data on people, but also clinical healthcare data. It was obviously done anonymously, but they had access to over 75,000 people, actually over 80,000 people, who had completed a PHQ-9, Patient Health Questionnaire 9. It's 9 because it's got 9 questions. And for our purposes, the reason that's critical is the 9th question is, in the last couple of weeks, have you had thoughts of ending your life or feeling that you'd be better off dead or something like that? But basically, it's a question that asks specifically about suicide. And the results, and I've actually got an error here because I went back and read the study last night to be prepared. It turns out that 80% of the people who eventually died by suicide in this study had actually said they were thinking about it. 80%. 60% of those who subsequently made a suicide attempt. So basically, asking people one question about suicide is a very accurate way to predict their risk. If I were to make a comparison, about 35% of those who die of a heart attack had elevated cholesterol. So asking one question about suicide is twice as good as a blood test is for predicting heart attack risk. So a lot of times we worry about, we say we can't predict 100%, and it's true, we can't. 20% of the people who died when they were screened either denied it, knowing that they were thinking about it, or maybe they weren't thinking about it at that particular time, and 40% of those who made an attempt. But compared to other medical indicators, the take-home here is that the screening is very effective. And so this is really the first of the 4 recommendations that I make for your team to consider. And the recommended action is to select an evidence-based brief screening tool and then to help your high priority sites to adopt. Now I say here intercept sites, that's really referring to the sequential intercept model for suicide prevention. Don will focus on this a little bit later. You may not be possible to do this everywhere, and you have to think about, who might be willing to take this on. You have to think about what are the sites where a larger percentage of individuals might be at risk, for example, an emergency room, for example, in mental health programs, and then what are other places that serve many individuals, but they may not be at as great a risk, like primary care offices. So you need to think about the yield, that is, what's the urgency of need in the population. You have to think about feasibility, what you can get done, and who might be willing to go along with this. At some risk, because everybody's got their favorite screening tool, and everybody's got reasons why theirs is the best and the other ones are bad. Mostly, I think that's kind of malarkey. There are 3 or 4 screening tools that are probably all roughly equally good. The developers of each one say that theirs is better than the others, and they all point out problems with the others. I recommend the Columbia Suicide Severity Rating Scale for several reasons. It is publicly available. It's free. It's been endorsed by both DOD and VA. So it basically is the screening approach that is in the water. And I think on the next slide, we just have a little screenshot of this. If you go to the website, what you'll see is that this Columbia system actually has a lot of different versions. And they have versions for kids and for adults and for detailed assessments and with dozens of questions. And I say stay away from all that stuff and use the simple version, which is shown here, which involves these 2 questions, 1 and 2. Have you ever wished you were dead or wish you could go to sleep and not wake up? Number 1. Number 2, have you actually had any thoughts of killing yourself? And if the answers to those questions are no, you can skip most of the details. And if the answer to the second question is no, then it goes to question 6. Have you ever done anything to end your lives? End your life. So basically, this is a screening protocol that was originally developed not for caring for people, but it was developed at a time about 15 years ago when there was this kerfluffle about kids getting started on antidepressants and then completing suicide. I think, Paxil or Prozac, I can't remember what it was. I think it was Paxil or Effexor or one of those. And so the FDA decided if we're going to be supporting trials of depression treatments, we need to figure out some way to predict which of those people are at risk for suicide and then require people to be screened who are in these clinical trials. So they did that. It worked pretty well. And then, somebody said, well, wait a minute, we could actually do this in the real world and save a lot of lives. So my first recommendation is to pick a screening instrument. I would kind of recommend the Columbia, and I'll talk later about resources that are available to brief people on how to do that assessment. Next slide. Oh, here's you see at the bottom of this, and as Don said, the slides will be available, but bottom right, there is actually a link to the website of what they call the Columbia Lighthouse Project, which is a whole website devoted to this screening system. And I'm not going to get into the scoring of it up here, but basically, we're not concerned about people whose responses are blank. We're concerned about people whose responses are red. They're potentially on fire, so to speak, with thoughts about suicide. So let's say we've put a screening approach in place and we identify people with suicide risk. Then what would we do? What does the evidence suggest? Let's go to the next slide. Oops. Let's go forward one. a minute. Okay. All right, let's go back to the previous slide. I had another slide that is not in this presentation that I want to just mention a little bit, because the old way of thinking about this problem is if somebody says they're thinking about suicide, we have to stop, drop, and take them to an inpatient psych unit. And it is turning out that that might not be a good idea. If somebody is thinking about suicide and they are not willing to work with us, they say they've got a plan, they say they've got the intention to carry out that plan, and they don't really want to talk about it so much, or if they're unable to work with us on a safety plan, which I'll get to in a second, then they probably have to be on an inpatient unit. But if they can work with us, we probably ought to try that instead. And now I get to the second recommendation, or the second and third recommendation. But in this case, we start with the evidence, and then I'll describe these interventions. This was a big study completed in the VA. You see in the bottom right, it was just published in 2018, so these are brand new results. And what they did in this study was they took individuals with suicide risks. They'd all been screened, and they did two things. Before they left the emergency room in that visit, they helped the individual complete a safety plan, which I'll describe in just a second. The second thing they did was they made a couple follow-up calls, telephone calls, on average 2 calls. And what I want to point out here is that this intervention goes directly back to Joyner's theory, because the calls are a method of breaking through that isolation and just saying somebody cares about you, we're interested in how you're doing, we want to stay in touch. So it combats isolation. And the safety plan is a way to help people create some distance from those thoughts of harming themselves. In other words, we want to try to reduce their capability for self-harm. You see the results here? This is a pretty small intervention. This is like kind of giving somebody a cholesterol med, but it's one visit to do a safety plan and a couple follow-up calls, and you see that it reduced suicide behaviors, which basically means suicide attempts, by 45%, and it doubled the likelihood that people would then come in for follow-up counseling. So let's look at the next slide. Let's go one more and go back to see if we have this. Okay, yeah. So this is a slide on the safety plan. You'll see that there's one way to think about the safety plan. It's just like a one piece of paper, one sheet, a template, but it's really not a form to be filled out. Obviously, the form should be filled out, and the most important thing is that the individual gets the form and takes it home, and it becomes a resource for them. But it's also an intervention. It's a way to work through with people what are some things that you can do when you begin to feel like this. If you keep it at a simplistic level, we start with things that the individual can do internally by themselves. Is there something else that you can think of at that time that would divert your attention? A lot of times people might say, I can't do that. It's too, the thoughts are too intrusive. They're bothering me too much. And then we could escalate that a little bit and say, well, let's try this. You know, there's this organization called the National Suicide Prevention Lifeline, and they have 160 call centers around the country, plus the VA has got call centers just for veterans. And if you have your phone with you, why don't you dial this number? I'll give you the number, and I'll step out of the room. You can just have a conversation with them for a couple minutes and see how that feels. See if you can work with them, and then if you can, you'll have the phone number programmed into your phone, and you can use it the next time if you need to. So the safety plan builds from internal activities to actions that people can take. And if we have worked with somebody and begun to establish that framework, then it gets to one of the most critical elements, which is to raise the question about, have you thought about what means you might use or how you might harm yourself? Can we do something about that now so you can stay safe? If there's somebody else at home, could we call home now? Would you be okay with having somebody else take storage of that weapon until you feel better and can have it safely? Or if you've been stockpiling meds, can we get rid of those meds and give you your prescriptions on a weekly basis so you won't have as many meds and you won't have to worry about overdosing as a strategy? So the safety plan is now a standard part of the VA's suicide care approach. I'll show you in a little bit a screenshot of a training course that's available to introduce use of safety planning. And the key thing about this is that there's now this research evidence about it. The safety plan stuff is free to use, and it is quite effective. So it's a one-session intervention that significantly reduces risk. Now, if somebody is in continuing care, let's say somebody is in a mental health program, as long as they continue to have suicide risk, and if they have suicide risk, we probably should be asking them whenever we see them in a mental health program, not just when they come in, because this could be ongoing. And if they have that suicide risk, probably the session with the therapist starts with, let's just see how you're doing on your safety plan and if we need to make any changes or update it, because that's the first and most important order of business. And after we help keep somebody alive, we can help them work on the other issues that they're concerned about. So let's go on. This is the fourth and final key point that I want to suggest to you. So the first was screening. The second was safety plan. The third one that I slipped in there, and we can talk a little bit more about, is taking steps to reduce the lethal means that an individual might use for self-harm. And this is the fourth point, and it goes back to the issue of connectedness. And the research evidence about this is kind of overwhelming, and it's so powerful that I'll dwell on it for a minute. This is actually the only evidence that I'll present here that we've had for a while, and this was from this study by the psychiatrist Jerry Mutto in San Francisco. This goes all the way back. I think it was published in 1990. And what they did was they had about 2,000 people discharged from psychiatric units, and half of them just got the usual approach on discharge, which is they got a referral for a follow-up visit and, kind of good luck. The other half got exactly the same thing, the referral for the follow-up visit, and then they got some handwritten letters from somebody at the hospital. I think one letter a month for the first year, and then they might have gotten a letter every 6 or 8 weeks after that for the second year. And what was astounding is that the letters alone contributed to a 50% reduction in suicide deaths, which is shocking on the one hand, but on the other hand, if you think about this problem of isolation, it's not surprising because people's feedback about this is that I didn't know anybody cared. And so it turns out also, I don't have the specific research studies here, but almost any kind of personalized follow-up that's been studied has been shown to be effective. So letters, postcards, texts, emails, phone calls, and nobody has specifically studied yet, to my knowledge, outreach from a peer veteran. But I am about 99.9% certain that if that is studied, that's going to turn out to be more effective than any of these other dimensions, because it's got more personal juice attached to it than any of these other approaches. So what I recommend for your teams is for them to implement a caring contact model that works for them. I don't want to suggest a particular approach because this may vary by setting. I'll give a couple of examples here. Some psychiatric hospitals or psychiatric hospital inpatient units have looked at this and said, well, you know what, when we discharge a patient, we've like punted the ball away. It's not in our possession anymore. It's in the community's possession. And so we can't be sure that they're going to do anything. So you know what, we're just going to do a letter to every patient that we discharge. We'll have the unit clerk, we'll have a standard form letter. They'll be simple. The unit clerk will type that up, and then when the treatment team is meeting the day the patient is discharged, people will sign it and put little notes on it, and then we'll send it out the next day. So they've just decided we're not going to get paid for that, but we're just going to do that approach. Another approach that's being used in some places is this is being used in some emergency rooms in Colorado. Colorado has a statewide crisis call system, and in these selected emergency rooms, they ask people after when they're leaving the ED, would it be okay if somebody followed up just to touch base with you? And if people say yes, the message goes over to the call center, and they make the calls because their calls are what they do. So these are several approaches, but whatever approach you decide, this is just such a high leverage action item that I recommend it for your attention. I want to conclude before we go to questions again with some resources that are available here. There's a website called zerosuicide.com, which has got more stuff than you can possibly use. But here are three. These are just screenshots of streaming video courses that are all high quality, that are available for free on that website. The top left, you see a police officer. I think it's the George Washington Bridge in the background. So this is how to do a screening using the CSSRS. And you notice it's interesting that this is being done by police officers and other individuals. That you don't have to be a therapist to ask these questions. At the top right, there's a great resource called Counseling on Access to Lethal Means that is a sort of a how-to work with somebody to think about reducing their access to means of self-harm. In the bottom left is a briefing on safety planning. I think that this is actually done by Dr. Barbara Stanley, who is one of the co-developers of this. So these are all available through zerosuicide.com. You might have to poke around a little bit, but these are free resources that are available to you, but more particularly available to your teams. Because the Zero Suicide website has got so much stuff on it, I would have a couple of people study it to try to figure out, what are the key resources for that your teams are interested in, and then to transmit that information directly. On the next slide, we have a couple of other resources that I'll mention for you, and these are both these are resources that were developed by very skilled people who have direct experience with suicidal thoughts and themselves, and in one case of taking care of people who are suicidal. So I'm thinking now about the one on the left, Now Matters Now. There's the link, or if you just search for Now Matters Now, one word, it'll take you through to this website. So this is developed by a friend and colleague, Dr. Ursula Whiteside, and the great thing about Now Matters Now is that it is a collection of very high quality, very brief videos on suicide and how to cope with suicide. The videos range from 30 seconds long to the longest one might be there's one of a veteran. Actually, I think he might be active military, talking about his experience that goes on for about 6 minutes, but that's long. most of these are very short and they're very high quality. So the people involved in this are all doctors and therapists, as well as suicide survivors. And Dr. Whiteside and her team is just about to publish a research study of this, where they had a little questionnaire that people could fill out when they were coming onto the site and when they were leaving the site. And so they don't know if this is it wasn't a randomized study, but they have results of almost 4,000 people who took this little survey. And basically, of the people who took the survey, about 28% of them said, when I got on this site, I was out of control. I was thinking actively about suicide. And after I was on the site for a couple minutes, I felt calmed down and okay for now. A very powerful message, and partly it speaks to the quality, I think, of the materials that are on the site, and partly it reflects the fact that suicidality can be overwhelming, and it can be potentially fatal. Dr. Whiteside talks about feeling like you're on fire, but it can go away pretty fast also if you're exposed to the right stuff. As a matter of fact, if you go to this website and look for, stop, drop, and roll, she's got a set of methods that people can use that are the equivalent of stop, drop, and roll if you're feeling like you're on fire with suicidal thoughts and feelings. The other website on the right, livethroughthis.org, is just another classy and terrific website that is dozens and dozens and dozens of personal stories of people who have attempted suicide and lived through it, which is where the title comes from, livethroughthis.org. And this is developed by a suicide attempt survivor and artist, Desiree Stage. And it's also just the quality of the pictures and the brief stories that people tell are very moving. So both of these are resources for caregivers, for peers, and also for people who might live with a suicidal intensity that I hope are helpful to you. So this is just to sum up the recommendations, and they basically, as we said in the outset, 4 things to do. The 4 things are: think of an approach to screening, think of an approach to safety planning. As a key part of safety planning, focus on reducing means of self-harm. And the 4th is to implement a caring contact model. And after studying all this for a few years and looking at the best stuff that's available, my belief is if we could begin to build this to scale, the way we started to do with cardiovascular disease death, we can in fact save a lot of lives. This is just my recommendations for how to measure all this, because I think we've got to be accountable for our results, and we also have to learn what's working for us and what's not working for us. So I wouldn't put all the effort in place to do this without measuring it a little bit to see how it's going. So I'd look, are people getting screened? Who's positive and who's negative? For the people that screen positive for suicide risk, are they getting safety plans? And can we confirm that the means were reduced? Which might mean not just a phone call during the session, but it might mean a phone call afterwards. Did the weapon get put in a safe place? And then the caring contacts. So these are the active ingredients of suicide care. Now, I think we're almost at the end of this session. Let me make a couple of other comments before Don brings us home when we go to questions. So one of the questions has to do with thinking a little bit about what sites are the productive ones for you to go after. With the sequential intercept model, we really emphasize acute care places or places where people may be in crisis. That's because, obviously, if they're in crisis, their risk is the greatest. But it's also true that the people with the very, very highest risk, the people that are really on fire, are not the biggest number of people. It's the people that are just like, they're not on fire today, but they're going to be on fire tomorrow. They're thinking about suicide. They're developing capability. They may be beginning to isolate, but they're not in the danger zone yet. They're not receiving mental health services. They're thinking about going to talk to their doc about this. So just looking at the data we have just in the healthcare sector, and these interventions don't apply just to the healthcare sector. They could be implemented at veteran centers, for example. But in the healthcare sector, we see that of all people that die by suicide, 45% saw their doc in the month before they died, and 70% of older guys saw their doc the month before they died. Older guys are not as likely to go see a shrink, so to speak. But if they're troubled, they may go see their doctor. So we know that physician visits in primary care are where the largest group of people go. We also know from the data that about 20% of the people that die had a mental health visit in the last 30 days. So most of the population doesn't have mental health visits, but the risk of people in mental health care is higher than the risk of people in primary care. And finally, a study shows that about 37% of the people who died by suicide had an emergency department visit in the last year. So this is the last year. It's a long period of time. And a mental health problem was not coded when they made that visit. So the implication is that people who go to emergency departments may have a lot of things going on: loss, injury, attempt, and so that's it's a group that is of comparable risk to people getting mental health care. And finally, the highest risk group of all is sort of ironically, I alluded to this before, people who are just getting out of a psychiatric unit. And their risk is, according to one study, 40 times higher than the general population. So even though they just were in the hospital, they weren't there long enough to change these behaviors. Suicide was not probably a big focus of the care they got. They probably got started on a medication for their mental health problem, but they were discharged within 4 or 5 days probably, and the medication hasn't really kicked in yet. And they may not have had any contact that really dealt with suicidal thoughts and feelings, unless you have very progressive psychiatric inpatient units where you are, in which case they're starting to bring that in. So I go through all that just to suggest that in thinking about where to go with these, so these are the high octane actions. Where to go depends on the likelihood that people will follow through and be willing to make the commitment to implement. It depends on whether it's a place of acute risk, and it also depends on whether it's a place with large groups of people. The last thing I'll say about that is that just right now, the leading healthcare accreditation organizations are raising their game on suicide prevention. And so this is a good thing to know if you're working with hospitals and health systems. So the Joint Commission, which accredits most hospitals in the United States, as of 2019, is going to be looking at suicide care, specifically for anybody in the care of the hospital who had a mental health diagnosis. They're going to be looking at whether suicide was asked about, whether something effective was done. So hospitals are thinking about this right now, so it's a good time to talk to them. And CARF, Commission on Accreditation of Rehabilitation Facilities, which is they're the big accreditor of mental health centers and probably of alcohol and drug programs. They've just changed their standards, making suicide care, basically these items, the very same items we're talking about here today, critical elements of their survey process. So those are just some thoughts about where the places are that you might want to explore connections to based on risk, interest, and availability. I just let this sit there. I don't think we need to hang on this. And finally, I'll just close with this thought. I'm now is maybe not quite a good a time to talk about airline safety as it would have been a few months ago before the 737 MAX stuff started to happen. But at least that we took action on that before we had an airline crash in the United States, and we haven't had a fatal commercial airline disaster in the United States for years because safety is a bigger deal in aviation, even with the risks, than it is in healthcare. So the other thing that this makes me think of is the movie Sully, where we have the example of Sully Sullenberger landing the plane in the Hudson River. And what I really am struck by here is in the movie, if you saw it, the Transportation Safety Board grills him because they have this theory that he should have done something different because the computers said, turn around and fly back to the airport. But he and his co-pilot demonstrate to them that given normal human reactions, even of trained pilots, there wasn't enough time to do that. And so at the end, they did the one thing that ended up saving lives. And at the end, one of the inquisitors from the safety board says to him, Captain Sullenberger, I know we've been giving you a hard time, but I want you to understand that we believe you're a hero. And his response is interesting. He says, no, I'm not. I'm not a hero. I just did my job. And my co-pilot did his job, and the flight attendants did exactly what they were supposed to do, and the passengers followed through with everything we asked them to do, and the first responders that came out to help us were great. So this is a message of everybody doing their job, which for me is a message of this challenge of suicide prevention. We've got to make this our job, and when we make it our job, as we did with heart care, we're going to achieve results. So thank you for that, and Don, I will turn it back to you for questions.
Thank you, Dr. Hogan. So at this point, what we're going to do is pause again for questions and answers. Based on the information you heard, I'm sure you had a couple of questions spark. Please type those into the chat box or the Q&A box, and we will answer those accordingly. What we're going to do is take this question that was submitted a couple of minutes back, related specifically to tobacco use and screening. So Deborah asks, Dr. Hogan, many clinics also screen for tobacco use and domestic violence as well as suicide. They express the length of time to screen, assess, and refer patients. Do you have any recommendations to streamline this process? Well, this is life or death. Do we get the same kind of pushback on the blood pressure check? Probably not. How many of us, or how many clinics object to the blood draw to do a cholesterol check? Probably not that many, even though the predictive rate of the cholesterol check is about half as good as the predictive rate of a single question. So I think at the same time we have to have sympathy for people that are overworked. And the second part of your question was, I think, the key one, and that is the fear that we might uncover problems and not know what to do with them. So, having said that, I think what we have mostly going on in this issue is a failure to take suicide seriously as a health problem that we should be paying attention to in the healthcare system. At least that's my primary focus is on healthcare. But it's going from not being an issue to mainstream. I mean, the Joint Commission now is saying, they're not saying screen everybody, but if you had a person who had a behavioral health issue and they died by suicide and they weren't screened, a hospital is going to get a ding. So I think we have to
operate in a space that recognizes that we are asking for something new. It is a real healthcare risk. Thankfully, the things that we're asking people to do, if there is a risk, are not uber complicated. They don't necessarily have to be done by the doc. They can be done by the physician's assistant. They can be done by a nurse. They can be done by a peer in many cases. So I think we have to recognize that this is a new challenge and be supportive and relentless at the same time.
Thanks, Dr. Hogan. Another question, actually there were two questions related to the same thing, related to the role of veteran service organizations or veteran peers in this effort of suicide prevention, and specifically screening.
This is it's an issue that is just developing. I talked about the key role of veteran service organizations and veteran peers with respect to doing the follow-ups. The question of doing the screening is one that I do not have direct experience with. I expect there is likely information on this on the website of the Columbia Lighthouse project, which is the website behind the Columbia Suicide Severity Rating Scale, because Dr. Kelly Posner, the leader there, has developed a version for families, and they've developed other kind of versions of screening for people without a lot of initials behind their names. So I think it can work if people have support, but that's just my opinion. I think what I would do would be to look at the Lighthouse project.
Thank you. Another question related to veteran service organizations. Do you think other organizations can implement caring messages, such as Veterans of Foreign Wars, to help promote mental health, or how would the message be?
I think that is a phenomenal idea because I think it accomplishes several things at once. I just have this belief that an outreach to a vet from a vet is going to be of higher value than from anybody else. I think the energy that exists behind the notion of don't leave anybody behind it's an energy that I think would still exist for veterans even if they'd served 50 years ago. And so I think it's a fit with the mission, and it would be highly effective. Now, whether people are willing to take it on, some people might not want to go there. Some people might think it's a change of mission. I can't speak to that, but if it can be done, I think it would be phenomenal.
Another question from Susan is, can you say more about why suicidal clients should not be sent to psychiatric units?
I'm really glad you asked the question. I'm glad you asked it that way. I shouldn't have said that suicidal people should not go to the hospital. I would reframe it as saying it might not be the best, or even if it's the best approach for a person, we shouldn't expect that it's going to solve the problem. I think a sensible approach would be if somebody, for example, if somebody is, going back to that to the Columbia scale, the rating approach that we didn't dwell on, if somebody really is on fire with suicidality, if they're having psychotic thoughts as well as expressing that they want to die and they have a plan to die and they're going to implement it as soon as they get home, then there's probably no way to keep them safe other than an inpatient unit, unless we have access to a great crisis program that is in our community, which usually we don't have. So it might be necessary, but if a person is suicidal but acknowledges they want help with it, they're willing to go through development of a safety plan with us, they're willing to discuss and make some arrangements for reducing means, and they begin to move from a place of desperation to a place of maybe I can get through this, then I think having them go to a hospital would probably not be a great move. And then there may be a whole bunch of people in between, and a different way to ask this question would be to say, if we think somebody has to go to a hospital, what help are they going to get at that facility for their suicidal thoughts? So if the hospital specifically deals with suicide risk as a part of their treatment, I would be much more favorable about having somebody go there. But that is, shockingly not a standard approach. The standard approach would be to, get started on meds and participate in some groups, and then when you convincingly deny you're going to attempt suicide, to be discharged. But we don't, for example, best practices would be a psychiatric inpatient unit that would have a treatment group focusing on discussing each other's safety plans, or how to develop better safety plans, or providing that kind of support. So I don't want to be anti-hospital. Let's use it for what it's good for, and let's use it when it's really necessary.
Thank you, Dr. Hogan. Elizabeth made the statement, I appreciate your distinction between ideation and actual risk and the appropriate responses for each. Do you see a need to change the narrative around disclosure of suicide ideation? She says, I find a lot of veterans fear hospitalization or emergency response.
That is a very good question. And I don't have a simple answer for it. That even though through Joyner's work and that Milner research and other things, we understand that ideation is only a weak predictor of suicide, to some extent, it all begins with thinking about suicide. There are many people who die by suicide who didn't think about it before they did it. If you sort of think about it that way. So it's a good place to begin, but we can't end there. And the concern that individuals have expressed to you, I think, are right on target. As soon as I say the S word, then all kinds of bad things happen. And they may have had an experience of going to the hospital where they didn't get any help with suicidal thoughts or feelings, and instead they got a medication they didn't like for a condition they didn't necessarily buy. This is also one of the reasons why, ironically, when people get out of a psychiatric hospital, those who have some degree of suicide risk are less likely to accept follow-up care because they don't think it will help them with their specific issues. So if we can create a space more where just acknowledging suicidal thoughts and feelings is not such a bad thing, and that's one of the great things about these websites, by the way, because I'm thinking again about the one video that I looked at on the Now Matters Now website of a veteran who talked about being suicidal, making an attempt, going through all that, and coming out the other side of it now with a mission of providing support to others in the infantry, and so if it can be seen as not something that's so shameful that has bad consequences, but it's something that happens to people and help is available for it, then hopefully we can reduce that stigma.
Thank you. We have time for a couple of more questions. The next one from Laura asks, and this is related to active duty military. We have an increasing problem in the active military with suicide-related events with our younger military members with little to no war experience. Our thoughts are now to use the ACEs screening to help identify issues. What are your thoughts?
Wow. Well, it's you point out something that is really critical there, and that is the public has sort of bought into what may be a false narrative about, deployment or active duty as being something that in and of itself increases suicide. And I think we understand enough to know that's not the problem. There may be things there that can lead to suicidal ideation, but there also are protective factors in the unit, in the culture, in the military community that are as strong as the risk factors. And you point out that sort of the younger active military may have increased risk totally unrelated to deployment. So you ask about looking at ACEs, and that, of course, is adverse childhood experiences. And one of the things that I can recall about the original adverse childhood experience study is that when they looked at individuals who had experienced different adverse childhood experiences, like child abuse, or living in a household with somebody who's an active user, or acutely mentally ill, or so. I think there are 9 different categories of ACEs. That the relationship with suicide was one of the strongest relationships. That is, the more adverse childhood experiences people had, the rate of suicide and suicide attempts went up very dramatically compared to some other risks. So I think that trauma in general, and child trauma in particular, are probably the greatest general set of risks that people are exposed to that can lead to these problems. Now, of course, having said that, the vast majority of people with all these problems never attempt suicide. The vast majority of people who have made prior suicide attempts, who are thought to be the group at the highest risk, only 7% of the people who survive a serious suicide attempt go on to die by suicide in their lifetime. So we tend to be strong and resilient. But coming back to your question, I think an approach that looks at trauma that people may have experienced and finds a way to respond to that trauma is very likely to be effective for multiple reasons, not just suicide.
Thank you, Dr. Hogan. I think we'll take, we have time for one more question, and it's related to law enforcement. So what advice do you have for law enforcement corrections officers who work with veterans in the criminal justice system? Should they screen and refer for resources as needed? Is there anything else of note?
Boy, oh boy, oh boy, is that a problem? Because the inadequate mental health system that we've got in the United States of America has kind of left law enforcement and particularly police officers as the de facto mental health system in many ways. And one of the other things that we thought we might cover in this webinar, but we haven't really covered yet, although I don't think you're missing a lot, is that finally we have some action that is starting to happen in this country to take that burden back from law enforcement by creating better crisis care systems. Right now in the United States, we have no national standards for crisis care. We all know that if you've got that pain in your chest and your left arm is numb, you call 911. But we don't have a 911 for the brain, and we don't have anything like the EMS system that we've created that's been life-saving for accidents and heart disease. But maybe that is starting to change. So what I would say is that the single recommendation that I can make in the short term, in response to your question, would be to explore the CIT model, which involves a commitment by law enforcement to get officers trained in crisis intervention, and the second part is often forgotten, a simultaneous commitment by mental health. If law enforcement commits to officer training, mental health needs to commit to a drop-off arrangement where people that are determined by trained officers to be in need of mental health care or other behavioral health care can be brought to some central location they can get the treatment they need instead of having to go through booking and jailing, which is going to be time-consuming, intrusive. It's going to take officers off the street, and it's not going to accomplish much. So CIT is present in many communities around the country. At a national level, maybe we're starting to make a little bit of progress on this. If you go to the website Crisis Now, one word, crisisnow.com, you'll see a report that we did nationally looking at this issue of crisis care and recommending that we get into crisis care starting at the national level. And our advocacy on this is starting to take hold. Advocates in Washington have got the budget writers in Congress committed to recommend for the 2020 budget a national investment in mental health crisis care that would begin to respond to that problem that you cite. This is the early stage. It's not in the president's budget. There's not enough money to do everything that's wanted, but that is being considered. And second and finally, there's legislation that has passed the Congress, actually came out of Utah with retired Senator Orrin Hatch and Representative Stewart, to think about designating a number for suicide prevention, just like we've got 911 for the brain. The idea is possibly to designate 611 for mental health crises, and that legislation passed. It didn't do the job, but it said, let's study this. And so SAMHSA and the VA and the Federal Communications Commission are just in the final stages of writing a report that looks at the feasibility and impact of a national crisis hotline system like we have in some states, like Colorado and Georgia and a few others. And so the short answer for that is the best short-term approach would be crisis intervention training with the commitment on the part of mental health as well as the commitment on the part of law enforcement. And the long-range plan is maybe we can get some wind under the wings of better crisis care in the United States, because we desperately need it.
All right, thank you, and thank you for the questions. As we wind down, I just want to pass along a couple of resources and things that are taking place across the country. So as Dr. Hogan did allude to a little earlier, the SMVF TA Center does conduct crisis intercept mapping for localities across the country, cities and counties. And this is a tool primarily designed for these 5 purposes: to identify those best practices for those intercepts that were discussed. I saw a comment about what should be done related to supporting family members. This tool is broken down into 4 key intercepts. Those are areas where communities can come together and help to support service members, veterans, or their family members to prevent suicide through the entire continuum. So it starts with Intercept 1, which includes the first contact areas, those primary care providers, benefits offices, family members, law enforcement, et cetera, and providing tools for those groups that make that initial contact with those service members and veterans. The focus primarily, there's an emphasis on that second intercept, that red area, and that's the acute care setting. So you're talking your emergency departments, crisis centers, mobile crisis units, et cetera. The key is making sure that connection is there, and that's the map part of it, between Intercept 1 and Intercept 2, that the folks in the community know how to identify risk and understand who to call for certain situations. And then moving on to Intercept 3, Dr. Hogan, I know, spoke about the folks coming out of acute care still being very much at high risk. That's the focus for that intercept. So what we try to do is help identify some of those best practices for folks transitioning out of acute care to ensure that they do not fall back into a crisis situation. And then Intercept 4 focuses on that ongoing treatment in the community. So in all, this entire map looks at in individual communities, how we create those connections and partnerships and collaborations in order to reduce duplication and increase the coordination and collaboration between the folks, the organizations and agencies around the community. So this takes place it's taking place now, and it will be taking place this year with several cities and counties across the country. And it implements those 4 key elements that were discussed throughout today's webinar: screening, safety planning, lethal means safety, and supportive contacts, which all have evidence to support their implementation. So we very much focus on those 4 key areas as we move through crisis intercept mapping. Just to talk a little bit about some of the other technical assistance that the SMVF TA Center provides. Of course, we do webinars such as this, in addition to learning communities, where we gather small groups of individuals from different states, counties, and cities to discuss specific areas, topic areas of focus as they relate to service members, veterans, and their families. We also do virtual workshops, which are very similar to webinars, although they involve much smaller groups than this. And then we do individualized TA calls. Some of the upcoming events, we have a conference July 11th and 12th that focuses on safe messaging and social media, connecting those service members, veterans, and families across different communities to those resources that they need. And we also have another webinar coming soon for those folks on the line who are with Mayor's Challenge and Governor's Challenge teams. There's a webinar focused specifically for those groups on June 4th from 1 to 3 p.m. So we do welcome those individuals. Additional resources, you can always reach out or get additional resources for the SMVF TA Center by going online. You can see the link there on the right-hand side of the slide. Again, if you go to your chat on the right column of this particular webinar, you'll see a link that's been provided. If you follow that link, you can get access to all of the slides you've seen today. In addition to this, the VA does provide suicide prevention toolkit on their website. It's great information there. And in addition, here's some additional resources that are evidence-based for crisis care and suicide prevention. So we very much encourage you to look into these. Crisis Now, that second document, was mentioned by Dr. Hogan. The CDC introduced a couple of years ago the Preventing Suicide Technical Package. It's specifically geared toward communities developing strategic approaches toward suicide prevention, as well as the other documents that you see listed here, all great resources to help implement some of these strategies. So at this point, we'll close out. We do appreciate everyone taking the time out of your day to join us. I see there was a few messages for Dr. Hogan. Those will, in fact, be passed along. And I do appreciate everyone taking your time. Thanks for joining, and please look out for future technical assistance from the SMVF TA Center. So thanks a lot. Take care.